How's it going, guys? It is 3:01 a.m. Thursday, August 4th here in Japan, and we have a challenging question for neuro for step 1 and step 2, okay? This type of question, exceedingly high yield, particularly on 2CK, when you do the Clinical Master Series neuro forms. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram, Mehlman_medical, mehlman_medical, links down below. Find me on Telegram. Links to the Telegram group and channel down below. Now start the clip. 59-year-old man, severe pain in the lower extremities for 2 hours. Examination shows marked muscle weakness of the lower extremities. Pulses are normal bilaterally. He is unable to void despite a strong urge to do so. Insertion of a catheter yields 450 milliliters. Which of the following is the most likely diagnosis? So let's just walk through the answer choices here. Choice A, amyotrophic lateral sclerosis, ALS, Lou Gehrig's disease. Wrong fucking answer. I'm going to make this real clean and easy for how you can answer ALS questions in USMLE. Okay, this is going to be real beautiful right now. There's 2 requirements in the vignette. Number 1 is you must have a combination of upper and lower motor neuron findings. That combo is the first finding. Okay, so upper motor neuron like Babinski sign, okay, hyperreflexia, lower motor neurons such as fasciculations, muscle atrophy. The second requirement is there must be no sensory abnormalities. Okay, so you can get a big fucking paragraph, this long rambling neuro question, and you see something in the paragraph relates to sensory abnormalities, instantaneously, ALS, wrong fucking answer, okay? In this case, wrong fucking answer. Choice B, Guillain-barre, wrong answer. So obviously very buzzy, high yield condition, ascending paralysis, decreased tendon reflexes. They'll be real slick with how they can describe the ascending paralysis. I've seen this in the 2CK neuroforms described as weakness of muscles in the lower extremities proximally and distally, and in the upper extremities, weakness of muscles distally. So that means that the muscle weakness has ascended already in the lower limbs, but it hasn't yet ascended in the upper limbs, okay? So as I said, they can be real clever about it. Obviously, barbecue, Campylobacter jejuni, okay? They don't have to mention that, and they won't oftentimes. Albuminocytologic dissociation in the cerebrospinal fluid, okay? So you're going to see high protein normal cells, and you're going to do electromyography and nerve conduction studies to diagnose, and to treat, you're going to do IVIG and plasmapheresis, okay? For amyotrophic lateral sclerosis, the treatment is riluzole, very fucking low yield, however. Guillain-barre, wrong fucking answer. Choice C, neuromyelitis optica, aka devic syndrome, wrong answer. Look, this isn't me trying to be fancy. On Neuro Form 6 for 2CK, there's a question where they give you a presentation that sounds like MS. Okay, they give you a woman who's like 30 and she's got miscellaneous neurologic abnormalities. And you're like, okay, it sounds sort of like MS. And then they tell you cerebrospinal fluid is negative for IgG oligoclonal bands, which is typically what we see in MS. And they just want to know the mechanism for the condition, okay? Students are like, what the fuck? Answer on that form is antibodies against aquaporin 4. Okay, as I said, fucking stupid, very strange, but it's on Neuro Form 6. The Clinical Master Series form. So when you get there, you're going to see antibodies against aquaporin 4 as an answer. And this is neuromyelitis optica, devic syndrome. Wrong fucking answer. Choice D, polymyositis, wrong answer. So extremely lengthy discussion. I made tons of audio Qbank questions differentiating polymyositis, polymyalgia rheumatica, fibromyalgia, etc. But polymyositis, you need to know that you're going to see weakness on physical exam and or increase in creatine kinase, whereas in polymyalgia rheumatica, you don't have those findings. Polymyositis, of course, anti-Jo1 antibody is very buzzy. You're going to do electromyography and nerve conduction studies. You're going to have proximal muscle pain or stiffness sometimes, okay? You can also see that in PMR. You can have a high ESR in polymyositis, and you're going to see a T-cell infiltrate in the muscle. Wrong fucking answer. Choice E, prostatic metastases, correct answer. Okay, so this is extremely high yield, as I said. Presentation here is cauda equina syndrome or epidural spinal cord metastases. Now, there's no mention of anything malignancy related in this stem, okay? And they don't have to do that. You just assume male over 50 who has urinary retention, this can reflect cauda equina. Okay, they don't have to give you saddle anesthesia, or perineal anesthesia. They often don't do that. Okay, students fixate on conus medullaris syndrome or cauda equina syndrome and the different findings. Honestly, USMLE doesn't give a fuck. Okay, the way they test cauda equina syndrome is they're just going to give you a dude over the age of 50 for prostate cancer, or they'll give you a woman generally over the age of 50 for breast cancer, or they can tell you a patient had a history of lung cancer already, and then they're going to give you urinary retention and pain in the legs. That's all they're going to do. And the answer could just be cauda equina syndrome. The answer can just be epidural spinal cord compression. Answer can be metastatic malignancy. This is on the Clinical Mastery Series forms, as I've said, many questions. And you're going to do IV steroids here, okay? When you suspect some sort of compression of the spinal cord where you have neurologic abnormalities, you're going to do steroids. And if they don't list steroids, you're just going to do MRI to diagnose. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.